yeah, on the lower toolbar. So you can choose whether it's English or French. So with no further, so let's move to the next session. I welcome Evaline Maziku, who will take us through the overall presentation. Karibu.
Thank you, Dr. Upendo. Good afternoon once again, team. As Dr. Upendo has stated, that we have sessions we'll be presenting. We'll start with the overview, then my fellow TZ team will continue with the other session. Next slide. Starting with the epidemiological context, this is by December 2021, the people who are living with HIV are estimated to be 1,700,000. This is the estimation according to this, but also for HIV, for the HIV prevalence currently is 4.8 for people aged 15 to 46 years. And the HIV infection by the year 2021 is 44,000. 29,000, these are the AIDS-related deaths. For the adolescents aged 10 to 19 years, it is estimated that 19,000 are living with HIV, where among them 57,000 are females. 93 children aged from 0 to 14 years are estimated to live with the HIV in the country, and 98% of pregnancies enrolled on ART were enrolled on ART for PMTCT, whereby 11% of mothers to child transmission. This was the data as per 21 December. 860,000 orphans are due to AIDS-related death. So you can see how how big number of the orphan in the country due to HIV. These orphans, as we know, are 0 to 17 years. Next slide. For the status of 95 status, this is as of March 2022, 89.7% of those who have HIV, they know their status. Next slide. Of which 99 of them are on lifelong ART, and 96 among those who are on ART have suppressed their viral load. So you can see how much Tanzania have struggled to reach where we are. That are the current number by 2022 March. For the prevalence of HIV, currently we are on progress doing another size estimation, but currently the number that we are using was from the Tanzania HIV Impact Survey of 2017, where the estimated number of PWID, people who injected drug, estimated population were 30 by then, and the prevalence was 36, where a male who have sex with female, estimation was between 41,000 to 71 at that time, where 25%, the prevalence HIV were 25%, and female sex worker at that time were estimated 155,000, where the HIV prevalence estimated was 26%, while the general population at that time, even currently, with almost 60 million, but the prevalence was 4.7. So you can see how this key and vulnerable population are fuel of HIV epidemic in our country. Next slide. This is what I've presented, the national cascade of ARV You can go to the next slide. Condom programming. In Tanzania, we use the total market approach, TMA, as found on the condom programming. This approach emphasizes the stewardship and coordination, which is led by the government to increase the equitable and the access of the condom within the country. So the issue of condom programming is not the issue of one institution or organization, but it has been taken, it is led by the government, but with the other support or with collaboration from other organizations such as UN agencies, development partners, private and investment case, and other partners. So through that, we have been using the supply and the demand data to segment the market and understand who is in need and how can be reached. So all this have been possible through the radio of the government with the collaboration of the organization that I mentioned. UN agencies, we mean UNFPA, UNAIDS, WHO, UNICEF, and the other development partners, private sectors, and also implementing partners. Another slide. The slide here shows the condom use knowledge and behavior, how condom have been used in our country, how the people have the knowledge or behavior towards the condom use. Currently, the overall among adults aged 15 years and older who reported have sex in the 12 months is 31%, which this is equal to 34.9% of female and 27.3% of females reported using a condom during their last intercourse with a non-marital, non-cohabitating partner. But among the sexually active persons aged 15 to 19, which is equal to 26.5%, reported using condom at last sexual intercourse with non-marital or non-cohabitating partner. This is according to this 2016-2017. Next slide. Among the female sex workers, 69.3% reported always using a condom with a regular client, though only 31.6% reported always using a condom with their steady partner in the previous 30 days. So you can see condom there is still a challenge of people having behavior of using condom in their sexual practice. For the case of PID with a non-injecting partner, 89% of males and 70% of females reported inconsistent condom use with their regular partner. Risky practice among PID in Temeke. This is the study of 2011. So you can see the high risk of the high prevalence of PID, and you can see how many are they using condom with their partners. You can see how still there is we still need more to increase more efforts in health education so that people they tend to use condom in their sexual practice. Among MSM, 43.2% did not use condom with their last casual sex partner, while 49.1% used the condoms with their last regular sex partner. This is according to condom use in MSM 2013. 71.6 on male and 66.6 of female aged 15 to 24 years shows knowledge that consistent use of condom reduces risk of contracting HIV infection. So this is the number, at least it shows how much people have increased the knowledge and having the consistent behavior of using condom and in order to reduce the risk of contracting HIV infection compared to other years or other groups that years. Next slide. The table here shows the knowledge of condom as method of contraception. Knowledge of condom as contraception. For the case of male condom, 94.8% of all women, 94% knows about male condom as the method of contraception. But for the case of married women, 95.8%, they know. Sexual active unmarried women, 98.9%. All men is 96.2%. Married men is 98.5%. And sexual active unmarried men, they have knowledge of condom as a method of contraception. 97 among them, they know. While for the case of female condom, 79% they know. For the case of married women, 80.8% they know. For the case of sexual active unmarried women, 89% they know. All men, the percent those who know about the female condom is 79.7%. And for the case of married men who knows about the female condom is 86.7%. And for sexually active unmarried men, 81%, they know about the female condom. This is according to this 2015-2016. So you can see still the male condom is more knowledgeable than the female condom. Next slide. The target stipulated in the National Multisectoral Strategic Framework for HIV and AIDS. This is according to the NMS4 Comprehensive Condom Programming Indicator, where the first indicator, general adult population. This means the age between 15 to 49. The proportion of adults aged 15 to 49 years who reported to have used a condom at the last sex with non-regular partner increased from 35% of male and 27.78% of female of the baseline value data in 2017 to 50 in 2020 and 95% in 2023. So that are the indicator to capture the general population at that age who has regular, who reported not using condom regular with the partners. Second indicator is the youth aged 15 to 24. So the indicator is the percent of youth between 15 to 24 who use the condom at last sexual intercourse, reported to increase from 42% of male and 37% of female of the baseline value data in 2016 to 60% in 2020 and 80% in 2023. Another indicator is about the key population. The indicator says the proportion of sex workers reporting using a condom with their most recent client increased from 32% of the baseline by 2013 to 80% in 2020, and we're expecting 100% in 2023. So you can see how the government itself, this is the National Multisectoral Strategic Framework. The government has also insisting the stakeholders in making sure that condom is among the other intervention that is followed up and is also measured. The aim is to increase the knowledge and behavior of using condom so that we reduce the HIV. So as in summary, the condom use or the condom programming in the country, it's not only for one organization, it's not only for government, but you can see there are many efforts which government as a lead managed to have the strategic plan, managed to have different studies in order to identify the gaps and making sure that we work on that gap, but also having the national multi-sectoral strategic frame which guides the country on making sure the condom is a comprehensive programming in the country. Thank you. I would like to welcome my fellow Dr. Hafidh to continue with the next slides. Karibu.
Thank you, Evaline. I apologize for the delay of difficulties with my internet access at this moment, but I can proceed. Next slide, please. Initially in Tanzania mainland, public sector condom was considered as the family planning commodity. Therefore, it was issued at the facility level. Later, the government came to realize that it is a bit difficult for a healthier individual to visit a facility in order to fetch a condom. Therefore, the solution towards tackling this situation was to establish condom dispensing outlets at community level so as to assist in safely storage of public sector condom and easily accessibility by the community members. The major challenge was to find a sustainable mechanism whereby these condoms will be continuously shifted from facility to community level and safety storage outlets. Also to ensure community members have discipline of taking condoms from these dispensing outlets rather than abusing the opportunity. Fortunately enough is that since 2003, the country currently had established multi-sector AIDS committees. We consider them as MACs in short, MAC, at each administrative level from regional, council, ward, and village levels, whose guideline has been revised in 2014. These MACs are chaired by a political leader and the executive officer heading their respective level, as well as comprised of members representing several umbrella organizations from community members, such as youth, people living with HIV, CSOs, religious leaders, and the public health facility in charge within the respective level. In this case, finally, it was later agreed that MACs should be as well tasked with the responsibility of ensuring public sector condoms are constantly available in community setting through the effective utilization of existing opportunities within the respective level. Furthermore, during the year 2021 to 2022, through the financial support of Global Fund, the country managed to establish and install condom dispensers at community settings in convenient sites identified by respective community leaders and local government authority. Frankly, the installation of these condoms has acted more than billboards in the sense that they have really created condom demand among community leaders and members, as well as establish a safety storage dispensing outlets. Furthermore, initially, these condom dispensers were created specifically for public sector condom, freely dispensed condoms. But later, in efforts to promote total market approach towards comprehensive national condom programming, during the second phase, these dispensers were created with dual dispensing outlets, whereby one side for public sector condom, while the other side possess a lock in order to store social marketed and commercial sector condom. Generally, the government has established a national multi-sector condom subcommittee chaired by the Prime Minister's office through TACAIDS and co-chaired by the Minister of Health through NSCP under the National Multi-Sector HIV Prevention Taking Working Group. These subcommittees meet on quarterly basis, currently under full sponsorship of UNFPA, and comprises of members from selected government ministries, departments, and agencies, academic institutions, youth-led networks, National Council for People Living with HIV, CSOs, private sector, that is representatives from social marketing and commercial sector condom institutions, as well as UN agencies and development partners, who also assist in provision of technical support. Moreover, the government through the Ministry of Health has established a reproductive health commodity security committee, chaired by the Minister of Health and comprised of members resembling those for Condom Subcommittee. But these committees take, both of these committees take leadership and ownership of the condom coordination structure and act as platforms for reviewing and supervising the condom programming in the country. Next, please. Our country has managed to establish HIV focal person from the national, that is TACAIDS and NSCP, regional secretariat. We have regional TACAIDS coordinators. We have regional AIDS control coordinators from the health medical response, and we have regional focal person from the non-medical response. And at the level of local government authority, we have 3 coordinators. That is, we have cancer, HIV, and AIDS coordinator, who's the non-medical. We have the district AIDS control coordinator, who's the medical response, and those we have 2 of them. Whereby among their key roles and responsibilities are to oversee and coordinate condom programming within their respective levels. Furthermore, our parliament has a specific committee that is responsible with HIV and AIDS issues, whose members are regularly empowered by TACAIDS and NSCP on globally prevailing issues related to HIV and AIDS, as well as assist to push all sensitive national HIV agenda that requires the parliament's approval. Next. Tanzania has conducive policy environment for triple protection with supportive policy documents. These national HIV and AIDS steering tools, that is the law, regulations, and guidelines and plans that are revised in line with the national multi-sector strategic framework, greatly assist in ensuring avoidance of unnecessary bureaucracy towards comprehensive condom programming and minimizing constraints, coming up with solutions as well as meeting international standards and authorization of implementable annual plans of operations. Next. In effort to support the development of comprehensive condom programming, the government had supported the development of the following policies, guideline frameworks, starting with the national HIV and AIDS policy that was developed in 2001. This policy was established in line with TACAIDS, and it had proven that there is an overwhelming evidence about the efficacy and effectiveness of condoms when used correctly and consistently in the prevention of HIV transmission. It has as well declared that good quality condoms shall be procured and made easily available and affordable. Furthermore, it has emphasized that the private sector should be encouraged to procure and market good quality condoms so that they are easily accessible in urban and rural areas. Coming to the health sector HIV strategic plan 5, that is 2012, 2022, 2026. This strategic plan is usually revised after each 5 years. Currently, we're in the 5th version, which has been recently revised during this year. Basically, it has addressed health issues, but incorporated HIV and AIDS-related medical response interventions as well. With the National Multi-Sector Strategic Framework, that is ending by 2023, that this framework is revised after each 5 years. This national framework is usually revised after each 5 years, and it has incorporated all medical and non-medical HIV and AIDS intervention, basing on the concept of combination HIV prevention intervention, as well as the global HIV primary prevention pillars. Currently, TACAIDS is coordinating the review process so as to come up with the 5th version. The National Multi-Sector Condom Strategy, this strategy greatly assists in guidance for the implementation of the National Comprehensive Condom Programming as well as total market approach. It is usually revised at each 5 years in line with the National Multi-Sector Strategic Framework. The costed strategy, the government with financial support from UNFPA managed to cost the strategy, the National Multi-Sector Condom Strategy, on guidance from the UN Condom Needs Estimate tool. This tool is expected to assist in the national condom quantification process, which is usually carried out biannually. The National Family Planning Cost Implementation Plan, that is the 2019-2023, basing on the reality that public sector condom were initially considered as family planning commodity. Therefore, this costed plan has really assisted in the quantification process before the National Multi-Sector Condom Strategy was costed. The National Condom Distribution Guide, that is developed during 2020, the establishment of this guide were among efforts that the government through the Ministry of Health had taken in order to come up with reliable and sustainable mechanisms that will ensure public sector condoms are constantly available in community settings, that is beyond health facility. And lastly, we have the circular, which is developed we have the circular which was developed in line with above guides, so as to ensure all government authorizing officers at all levels to timely implement the above guide as per national level instruction. I would like to welcome my colleague, Dr. Mariam, to proceed with the second presentation, the next presentation. Thank you.
Thank you, Dr. Hafidh, and thanks to Evaline and Tanzanian colleagues. I'll go through the challenges and lessons that we've learned from the process of implementation of condom programming in the country. So we've had a lot from my colleagues Evaline and Dr. Hafidh on what is happening in Tanzania in terms of HIV prevalence and the leadership approach that we are taking as a country in maximizing and strengthening condom programming in the country. Now we have a number of lessons and best practices that we've learned in the process, and we believe that it's important to share with you as a larger audience and probably scale up to your countries, or probably come and learn from more from us. Dr. Hafidh has talked of the multi-sectoral meetings or technical working groups that we have. First thing that we are proud of that is making us being able to see the effect of condom programming in the country. So the existence of functional national multi-sectoral condom programming and HIV prevention coordination structures have really put us in a better place to not only maximize implementation of condom programming, but also monitor, evaluate, and report at the end of the day. Through the National Multi-Sectoral Condom Subcommittee and the National Multi-Sectoral HIV Prevention Technical Working Group that also Dr. Hafidh talked about, we have been using this avenue to discuss what is transpiring in the country in terms of HIV prevention and condom programming. For example, in the condom subcommittee, we use this forum to address the status of condom programming in the country. How far are we in terms of stock status of public sector condom, commercial sector condom, and even social marketing condom, and how best we can make sure that we reach the beneficiaries that are supposed to be reached with the condoms at the end of the day. And we've also used the National Sector HIV Prevention Technical Working Group to look at not only the condom aspect, but also we go further and look at the KVP and even VMMC and combine all together as part and parcel of combination HIV prevention, which at the end of the day, it also strengthen the process of condom programming and later on support the beneficiaries who are in need of condom as part of combination HIV prevention in Tanzania. So that's a first best practice that we believe is important to share with you, the existing of functional national sectoral committees that usually meet quarterly with diverse group of stakeholders to discuss about condoms and HIV prevention in the country. The second one, I'm glad that also Hafidh talked about the number of strategies, policies, and guidelines that we have. One of the things that Tanzania has really invested on is having policies, strategies, and guidelines. And the good thing about us, whenever we're creating another or a new guideline, or we're reviewing an existing guideline, or we are trying to look at what is happening with the current guideline, we always try and link with other existing guidelines. For example, if we are, let's say, reviewing national sectoral condom strategy, we always link what is in the National Coastal Family Planning Implementation Plan. That's just an example. We do our best to link what we're trying to do right at time T with what is there in the policies, in the strategies and guidelines that relates to HIV. So we can link the condom strategies together with what we have in the reproductive, maternal, neonatal, and adolescents and child health strategy, so that to make sure that we don't miss anything in between and capitalize into these guidelines and strategies to make sure that we hit all beds with a single stone using these different strategies. That's another best practice that we've seen from our country. And another one is that there's a strong partnership between government, UN agencies, and other development partners. You can imagine all these diverse group of stakeholders. So we always come together and sit down as one, as Tanzanians, regardless of where you're working from, to address the existing challenges that are facing the country in terms of HIV prevention. So we sit together, we work together, we develop plans together, and at the end of the day, we implement and monitor together through this strong partnership between government, UN agencies, other development partners, and even private sector that we've been working with. We've also talked, Hafidh has also talked about the existing community structures. I'm not going to dwell much on that, but we have this, this governance system that starts from the national level to the community level. So whenever we talk of, say, condom programming, we not only end up at the national level, but we also consider the community structures and leadership structure that is at the community level to make sure that we also engage them. For example, most recently, we're engaging the ward executive officers and village executive officers in understanding the national condom distribution guideline and how best they can use their influence in communities to make sure that people are accessing condoms at the community level. So that's another best practice that we thought we should share with the team that has also helped our country to strengthen the condom programming. We also have what we call the community unified system as a solution for data capturing from the community to facility. However, we still need to work on this to strengthen it, but it has really shown us that it's important to capture data on what is happening at the community level. And it's something that we also argue for other countries to try and scale up to see how best we can capture, how best they can capture data at the community level to the facility to see what is happening, what is transpiring at the community. And also lastly, we've established condom outlets within community settings that has triggered high condom demand than installation of billboards. We understand when there was the days when we had the high prevalence of HIV, we're focusing mainly on billboards and adverts, etc. But now we shift our focus into establishing condom outlets within community settings so that we use the existing resources to go to the last mile consumer so that to be able for this person to use the condoms that are available for them to use at the community settings. So these are the 5 best practices that we thought they're really helping the condom programming and HIV prevention in the country and have strengthened the process of implementation, monitoring, and reporting in the country that we thought we should share with all of you. And probably if you'd be interested to come and learn from us, we'd be more than happy to host you. Now, if we go to the next slide, yes, we have a lot of best practices that we've learned. However, as a country that is still in the lower middle income country, we still have some gaps that we need to address to maximize the effect of condom programming and to also see the effect of combination HIV prevention that we are really pushing so that we reach the 95, 95, 95. So one of the challenges that we've observed is that we're procuring condom at the national level, we are distributing to the facility and to the communities. However, inventory taking for the last mile condom distribution is still a gap. We've mentioned that we have this system that is now capturing condom at the community level. However, that system, that inventory taking system is not that strong to make sure that we capture what is happening at the community level. After we distribute, let's say, condom to the facilities, probably they are taken by village executive officer to a particular condom dispenser in a hotspot to get the inventory of what has transpired in this for this condom that we are taking to the a particular hotspot is still a gap. So we really need to strengthen the inventory taking for the last mile condom distribution. Leaving that alone, we also have a gap in condom M&E system from the community level to the national level. There are no clear indicators and there's no clear M&E system that says that we're implementing condom programming in the country, and this is how we are going to measure the impact. These are the indicators that we are going to measure at the end of the day to see the impact of condom programming in the country. So that one is also another gap that we we are still working as a country, and the good thing is already our government has already started discussion with the number of donors and themselves to make sure that we create this strong M&A system at the end of the day to measure how the impact is. Another challenge I think most of the countries are also facing, we have limited domestic resources for combination HIV prevention, and of course, specifically on condom programming. There was a dwindling resources from donors, which has also impacted us. And there's limited domestic resources that is supposed to be catering for combination HIV prevention. That limit us to scale up or bring in new innovations to support combination HIV prevention and specifically the condom programming in the country. And lastly, in our country, we have limited researches on condom. Our data mainly depends on the surveys. For example, we have what we call Tanzania HIV Indicator Survey. We have Tanzania Demographic Health Survey. We've recently conducted our national census. So in most cases, we depend on these larger scale surveys that are done by the country. And we have limited resources to do researches on condom. For example, condom use, preferred distribution points, what the consumers want at different levels. We're still missing that information. So that's another limitation that we have that really that hinder us to get a clear picture of what is transpiring in the country when it comes to condom programming. I think I'll end up there and invite my other colleague who will continue with the presentation. Thank you. Back to you.
Thank you, Dr. Mariam. Thank you, Dr. Hafidh, and thank you, Evaline, for presentation. Now I welcome questions. Yes, well, I welcome questions to Tanzanian team to respond after their presentation. But to start with, I see there are already quite a number of questions in the chat box. Yes, I'll read them and then quickly Tanzanian team can just jump in and respond. So the first one is saying, please kindly share your question. Oh, sorry. The first one is saying, how does TACAIDS ensure adherence and implementation of policies and regulations? Dr. Hafidh, I think, is ready to respond that one. Dr. Hafidh? Hello?
Yes, Dr. Pendo.
Yes,
thank you.
There's a question on policies and how does TACAIDS ensure leadership to adherence to the policies and regulations in place?
Okay, thank you. I appreciate for the question. TACAIDS has representation at the regional and local government authority levels. We have coordinating team, regional coordinating focal person, and we have cancer, HIV, and AIDS coordinators who deals with non-medical response, and they are the one who really assist us in ensuring that the policies and the regulation guidelines are adhered to. Although at times it becomes a bit difficult to do it fully because of restriction, constraint of resources, but that's the way we usually do it. And we tend to have quarterly meetings. During these quarterly meetings, as we'd say, that we have the HIV prevention multi-sector HIV prevention technical working committee or group, which meets quarterly, and it has 3 subcommittees. That is, we have the condom itself, as we are talking about, and we have the key and vulnerable population subcommittee, and we have the adolescent and young adult subcommittee. So through these subcommittees, that's the platform where, as we get information, it acts as a place whereby we come up with knowledge on what's really going on, what's really transpiring at the regional and local government authority. As all these subcommittees, there has representation from the regional and local government authorities. Hello.
All right. Yes, thank you, Dr. Hafidh. Okay, maybe I should quickly read through all the questions that have been posted here, and then we'll respond. Maybe some of them you'll respond, and some of them other Tanzanian team will respond as well. So there's a question that says, it's so impressive to see Tanzania is using TMA for its condom program. Based on this, how much of the market share has been taken up by private sector? What strategies were used to encourage private sector contribution to this to the program? So another question is, how do you translate condom distribution to utilization? And we have another question that says, are community structures and community-led organization direct recipient of funds for condom programming and leadership roles they take up, or is this still quite centralized? So I think they're asking whether the community-led organizations, they're one of the direct beneficiaries of funds, or it's still heavily centralized. And another question is, so let's start with those the three of red ones. So I think the market share in Tanzania, for the market share in Tanzania, Dr. Hafidh, can you respond that one? The TMA.
Currently, in fact, we are initiatives are still ongoing to ensure that we strengthen the TMA, and but the good thing is that we have members of the social market, as I shared with you, the social market and commercial sectors institutions. We have them on board within the subcommittee, and we have a reporting template which captures the information on the stock which they have, and the amount which have been distributed, and the balance brought forward. So through that, at least it gives us a snapshot of what's really prevailing. But we are still coming up, because still we don't have many players for the social marketing and the commercial sector. So now the strategy is to ensure that we promote social marketing and commercial sector, so as we succeed in achieving the total market approach towards condom programming. So this will be implementable once we make sure that the price is lowered, and we have so they can compete on the prices. And because as we go, the public sector condom itself cannot be enough for the community members in place. So what we want to prioritize is this public sector condom goes to those who are those with low socioeconomic status, and social marketing commercial sector is taken aboard by those who can afford to purchase. So in the sense of total market approach, sincerely, we are coming up. But we still have few players within the social marketing and commercial sector. So as we need more players, so as they can compete and lower the price. Thank you.
Thank you, Dr. Hafidh. Another question was whether the community structures and the community-led organizations are the direct beneficiaries for the condom programming funding, or is it still centralized? So I'll take this one. Yes, the community-led organizations are among the, Dr. Mariam, karibu. Dr. Mariam?
Are you saying something?
Oh, yes, I saw you open your mic. I thought you wanted to.
No. That wasn't me.
Yes, so the community-led organizations among the beneficiaries of the funding for condom programming. So the practice is that the government is supported with, the government is in charge with procuring the condom, the product procurement of the public condoms. However, when it comes to implementation and operationalization, things like distribution of the condom dispensers, installation, making sure that the condoms reach the recipient, and it is around advocacy of condom use. That is done by the community-led organization or the community, the CSOs. And so they are one of the beneficiaries of the funding in Tanzania. For instance, we have TAYOA with the leading organization that implement condom programming, and they're one of the direct beneficiaries from the Global Fund. So that, yes, is not solely centralized. So the government receive part of the funds, and then the rest goes to the community-led organizations. I hope I've answered that one. Well, I'll keep on reading the question. I see there are quite a number of them here. So this is from Lucy. It is, yes.
Yeah, I thank you, Tim, for the response of the question. I would also want to respond on the question you mentioned. How did the question asked, how did you translate condom distribution to utilization?
Yes.
Yeah, we usually count number of condom utilization by depending on condoms distributed. So currently no actual data on condom utilization, but we rely on distributed condoms. Yeah, that's all that I wanted to respond on that question. Hello?
All right. Yes,
Yeah.
yes. Thank you. So there's no direct, it depends on the number distributed, but not necessarily it means that they've been used. Perhaps maybe that's an area for research later on.
Sure.
See that, yeah. Thank you. So another question says there have been stockouts of condom in Nigeria, particularly for key populations, and this is not a good thing for HIV response. My question is, was there a time in Tanzania, was there a time the Tanzania team had stock out of condom for key populations, and how was the issue addressed? What best practices can be put into place to avoid stockouts of condom? Dr. Mariam, I welcome you to respond to this question.
Okay, to be frank, I didn't. Can you come again with reading the comment from the chat box, please, if you don't mind? Yes.
So we have a question from Nigeria. I'll assume that currently they are facing condom stockouts, particularly to the KVP, to the key and vulnerable populations. So they're reciting, they're asking, maybe there was an instance in Tanzania we had a stockout situation. So how did we go about it? And what are the best practices in place to avoid stockouts? I think the question is in ordering and procuring.
Okay, thank you. I'll try and respond, and probably my government counterparts will also chip in. Maybe first to clarify to our colleagues is that in Tanzania, we don't separate condoms as for them to be used for a specific group. So when we procure condom, is for dual protection for everyone who is in need of condom. We don't say that this is for a particular population group and this is not. That's the first thing that we'd like to share with our colleagues. And actually the condom stockout, of course, as a country, we faced incidences where we had condom stockout at the community level. The most recent incidents happened a few months ago, where actually we did not have a stockout at the national level. The condoms were there at the national level, but they were yet to be distributed to reach the beneficiaries. So at the end of the day, impacted the condom availability at the community level for those who are in need. So what we did actually, we utilized the multi-sectoral condom subcommittee that we talked about, the technical working group. And as partners, as members, we were able to the government came up with an idea that they should write a letter to the health facilities, to the regional medical officers and district medical officers, for them to quickly order condoms from the national level so that they can be distributed to the facilities and at the end of the day reach the community. And actually that worked because actually of the influence that this technical working group, this committee that has to the whole process of condom programming in the country. I hope I've responded to the question, and please feel free to say if I haven't. Thank you, and back to you, to my colleagues in Tanzania, if they can add anything.
Thank you. In addition to that, yes, as Dr. Mariam has explained, that at one point we also faced stock out, not in terms that we did not have the commodities, but the commodities were still at the central level. They had not yet been transferred to the community. So as a government, that's when the government took leadership and decided to write a letter to all development partners and actually distributing targets. So on top of their own targets, like we all know that different development partners have their own targets based on their programs they are implementing. So the government had calculated new targets based on the demand that's out there in the community, and distributed among the development partners to cater to the deficiencies that was there during the condom stock out. So that really worked out. And I would say that would be one of the best practice when the government actually took leadership and decided to do quick mathematics to calculate what where the difference is, and then it worked. And it also shows good partnership between the government partners who also agreed and just responded quickly, and the condoms were available to the community again. So I hope that's elaborated a little bit further. So another question says, kindly elaborate on the condom dispensers that have dual purpose, distributing free and free for distribution and social marketed condoms. So I think the question is asking the practice here on the dual dispensers condom. Dr. Hafidh, please respond that one.
Okay. In fact, for the dual dispenser condoms, we ensure that they're installed in institutions and night pubs, in lodges, hotels, because so as one can monitor for those who need social marketing and commercial sector. But for those which are merely for the dispensed condoms, they're installed at the public areas, hotspots, because if they're installed in areas where they cannot be monitored, that means it will be useless, it will be wasteless because the area, the column which needs to be locked, which have a lock for those social market and commercial sector, cannot be used. So we usually specify the installation sites to be on institutions and areas where they can be monitored. One can monitor and sell those for social marketing and commercial sector. Thank you. Hello.
Yes, thank you, Dr. Hafidh, for responding that. I'm trying to see if they have any more questions on the chat. So I think we have really answered to all of them. Let's see if we have any hands up this session. So any other question, or anyone who would want something, would want further clarification on anything? Because I see, I don't see any hands up. And I think I've actually gone through all the questions in the chat box. No? Or maybe Team Tanzania, do you have any question to the participants today?
Yes, Pendo, we do have.
Yeah. Because now they cannot ask us questions. Now we'll ask them questions.
Yes.
All right. Thank you. Sorry, Mariam.
Before I do, there's someone, Namwinga has risen his hand. So maybe you can hear from her first.
Yes, please. Welcome.
Hello, good afternoon, everybody. My name is Dr. Namwinga Chintu, and I'm based in UNAIDS Geneva. I'm the global coordinator for the Condom Strategic Initiative. And I'm sorry, I may have joined late and missed some of the presentation, but I wanted to hear from you what methods you are using for your condom quantification.
Thank you, Dr. Namwinga. Dr. Mariam, please respond to that one.
Thank you. Again, I'll respond, and then Dr. Hafidh can also support. So of recent, Dr. Hafidh has talked of the National Multi-Sectoral Condom Strategy. And this year, UNFPA has worked with the government, meaning TACAIDS and other ministries, departments, and agencies within the government, and used the condom estimation tool, the UNAIDS and UNFPA condom and resource estimation tool, to do the costing of the National Multi-Sectoral Condom Strategy. So we've used that one to do the estimation of the condom needed and the resources needed for condom programming for the strategy that goes up to 2023. I hope I've responded to your question, Namwinga Chintu. Thank you.
Very well. Thank you. It's good to see more and more countries, operationalizing the CNET. So thank you for that.
All right. Any more questions? No? Now, Dr. Mariam, you had a question. You had a question for everyone, or maybe for ourselves.
I had a question to the person who talked about the condoms for KVP. I just wanted to know, how do they separate? How do they separate to say that these are the condoms for KVP? Do they have that system, or what exactly are they? What exactly do they do to address that these are condoms for KVP, if they do have such a thing in the country? Thank you.
Thank you. That's a great question. So I think this question came from Nigeria, or anyone from Nigeria can respond to that one.
Hello? Which of the questions came from Nigeria?
Yes.
Could you repeat the question for Nigeria?
So Dr. Mariam is asking, I think one of the participants from Nigeria recited that you're currently facing stock out for condom in the country for the key and vulnerable population. I think maybe it's for general population, but particularly of interest in the key and vulnerable population. So Dr. Mariam was asking responded to that one, because the question, first of all, the question was to Tanzanian team, if we've ever had, faced the condom stock out in the country, and we did respond to that question. So one of the things Dr. Mariam explained is that Tanzania, we do, when we calculate for condom need and order, we just order condom for the general population, and even the supply goes to the general population. So the question from Nigeria was that they are currently facing condom stock out for the KVP. Now, Dr. Mariam's question was, how do you do that? How do you calculate that these condoms, they are for KVP, and how do you get the data that currently we have shortage for condoms for KVP and maybe not the general population, if I got it correct? Madam?
Hello?
Yes.
Yeah, I'm Kingsley from Naka, Nigeria. When we say we have condom stock out is condom stock out for HIV program. If the one person who mentioned that was talking about because he or she is doing key population programming, it is not that condom for key population is stock out and maybe the general population have condoms. We do quantification for HIV program across the populations. But if we're looking at, there was a question I asked about condom procurement. For us here in the country, we don't do procurement jointly with family planning. So that may be the issues we're having with condom stock out. Maybe have condoms available for family planning programs, but for HIV program, our condoms will be will have stock out in most cases. And by the time we also go in line with our quantifications as we are doing now, trying to know condom use across the states so that we don't put condoms where they are not needed. When you see stock out in an area and there's condoms in some areas, you may know that maybe the need for condom, the condom need of those areas where they are stock out, you need to increase the number of condoms for those areas. So for the person that say we have condom stock out for key population, we don't have condom for key population, we have condom program for HIV program. And when they are stock out, it's stock out for HIV program. Thank you.
Can I also, my name is Abatunde Adelek, UNFPA. Can I also add that, just like what Kingsley said, that condom stocker might be peculiar to a certain program. And what we've started to do in conjunction with NACA is to ensure that at the subnational level, we begin to strengthen the HIV prevention technical working group in all the other states. So all the key stakeholders in all the states will come together, and then it will be easy for us to be able to understand their condom needs and then ensure that programming is done. Just like what Kingsley said, at the health sector level, usually there's condom, there's no condom stock, but it's at the HIV program level, because prevention for us is more at the community level. It's more to people directly. And so if you are doing a programming and it is not linked to the condom programming in the country, you have these issues like that. But it's something that we're addressing. And with the quantification we've done for both condoms, lubrications, and everything, and for the synergy that we now want to start having between HIV and family planning sectors in terms of condom programming, some of these issues will be addressed. Over.
Thank you. Thank you for clarifying that. So let's see if you have further questions for this session. I don't see any hands up.
I had earlier asked a question in the chat box. I want to know, maybe I joined a little bit late because I'm also in one of our regional meetings out of Abuja, to know the best practice about, just like Dr. Adeleko just said, condom procurement for these two sectors of HIV and family planning. What are the best practices of procurement, not quantification? We can do quantification, but procurement, how do you synergize the quantification, the procurement? So we can learn from that. And maybe as we are trying to go across, building capacity across our regional and state level condom programs, we can, tap from such best practices. Thank you.
Thank you. Okay, so Dr. Mariam, can you respond to that? The question of procurement.
Yes. Dr. Hafidh will be in the best position to respond to that.
Sure, Dr. Hafidh.
Dr. Pendo.
Dr. Hafidh.
Hello, Pendo.
Yes.
Dr. Pendo, okay. We have that committee which deals with family planning, which I'd say that members, almost the members resemble those for the subcommittee for condom, which is under the Minister of Health. They usually quantify condom with regards to the real requirements for the family planning. And at the National AIDS Control Program, we have also a team that which is under the commodity, supplies and commodity. Maybe Evaline will clarify more. So the one for the National Family Planning, which meets quarterly, it deals with family planning requirements, required the commodity that is specifically a part of other family planning commodity deals also with the condom quantification for the family planning. That is the Reproductive Health Commodity Security Committee. And for the condoms required for HIV prevention, or the other dual protection, that's STI and HIV prevention, usually it's dealt by a separate subcommittee, which is under the National AIDS Control Program, which meets almost twice a year. So maybe Evaline can have something to share more on this. But we have these two subcommittees which One is for the family planning code requirement, quantification family planning condom requirements, and the other is for the HIV prevention requirement. Evaline, is there anything which you can maybe share with our colleagues concerning the committee with for reproductive health? Evaline, she might not be online. Huh? Thank you. I think that's as far as I'm concerned, that's the only thing that I can share. Although through the CNET, the Coordination of Sector Condom Strategy, we are promoting the Family Planning Committee to also use the CNET. That will be nationally used.
Okay, thank you, Dr. Hafidh. So I think what they're saying that so currently family planning condoms are ordered differently. So maybe the Ministry of Health and solely the UNFPA in Tanzania, but then for prevention condoms is the one we use the CNET, and we use the CNET for procuring for procuring. And then what we're doing right now for quantification and procuring, for quantification later on procurement. So what we're trying to do right now is to advocate for the family planning condoms and prevention condoms to be quantified, to use the CNET for quantification and later on procurement, to have one system. So we still have not reached there. We still have some parallel system when it comes to procuring condoms for family planning and condoms for prevention. Thank you.
Yeah.
All right. So do we have any questions?
Going on from your explanation now,
yes.
How do you close that gap of maybe when you just like Dr. Adeleke also mentioned from our country here in Nigeria, when you don't have condom for HIV and you have for family planning, how do you go about closing that gap? Because most of the condom needs are from the HIV program than in the family planning. So if you're getting the procurement of condoms from the two sources, and you're like we do here, we have quantification, but procurement is done from different programs of HIV and family planning. So if you may have, that means in your country also you may have condoms for family planning and you don't have condom for HIV. So how do you go about that?
All right, that's a nice one. Dr. Hafidh, do you want to take that one?
Pendo, that's among the challenge we are facing. So you find that at the community level, they tend to see how they can solve that problem. So our focus is to solve that gap, that challenge. It's among the challenges which we usually face.
So we are learning that this is a shared challenge for across nations right now. We have Nigeria and as well as in Tanzania, that we have two parallel systems. Family planning condoms, and then we have prevention condoms. And then when it comes to stockouts, you might find that family planning condoms are still there, and then prevention condoms are the one that has finished. So
since we have a little time left, I appreciate the fact that you use total market approach for condoms like we do here. But how do you go about the issues around standards and the influx of unbranded condoms?
all right, Dr. Hafidh, karibu.
Asante.
Hello, Pendo.
Yes, Evaline.
Okay, thank you. Pole, nilikuwa kidogo na nimetoka. Yeah, thank you. I had the question, kwamba how are we doing for the issue of ordering or quantification the condoms in a parallel way, from RSH and the condom for HIV prevention? Is that the question,
Yes, that was one of the questions.
Okay, according to the procurement department, All condoms are requested from MSD, medical department. So are the one who procured the condoms. So it may depend, there is the system called ELMS, where the facility used to request the condom according to what they consume. Same to the facility, same to the condom. As we know nowadays, the condom will be requested by the facility, and from the facility to the community. It's another system that the community health worker checks are the one who took condom to the community. So that's what's happening. Even for quantification, so they will use the data from the facility for quantification process in making sure that the facility, they got the condom according to their needs. That's all. So we don't have parallel procurement. All condoms are procured by the MSD.
Thank you, Evaline, for clarifying that one.
Maybe Pendo.
Yes.
Pendo. So is that Evaline, the issue is that once the condom are available, they have been issued from MSD to facility. So there are those for HIV prevention and there are those for family planning. Out of stock, how do we compromise on the use of the family planning, HIV, or do we just consider all of them for HIV and family planning? That was the concern.
Yeah, you know, condom is a dual protection. So we don't consider this is for family planning and this is for HIV prevention. As long the facility is out of stock, first we have this system of redistribution. The facility with the high stock of condom can redistribute to the nearby facility which is out of stock. Same, the redistribution can be done within the facility. Maybe to the CTC, they don't have condom for HIV prevention, but the RCH they used to redistribute regardless of condom for family planning or for condom for HIV prevention. Thank you.
Thank you, Evaline.
The question was that, you know, that condom for HIV program are majorly for the community, while for family planning is for the health facility. So when you don't have condoms for HIV in the communities through the CBOs and maybe the user community, and you have that in the health facility for family planning, how do you, synergize to ensure that maybe condom leaves the facility to come into the community, since you don't have that barrier in using condom for HIV for family planning? How do we go about?
Thank you.
Also, I also asked a question around issues of, since we appreciate total market approach, how do we ensure standards and standard quality of condoms and also influx of unbranded condoms that don't have names? People go out to any country and come with a bag, and because it's not checked by customs as a bad goods coming into the country, how do we go about that?
Okay, thank you. I will respond for the first question, then the second question, I think Dr. Hafidh Ameir will take condom. The facility is the one which is responsible for ordering and the monitoring of the condom. That's why the condom will be requested by the facility, and even distribution will be at the facility level. So the community will get the condom from the facility. This is for monitoring, but also for Israel implementation of the service. I don't know if I've responded well to your question, or I noted well your question, but that's what I wanted to tell you. It's easy. We don't consider this condom is for family planning. This condom is for HIV. The facility will be responsible and accountable for the number of condoms they received as the facility. So within the facility, they will know how many condoms has been ordered by the RCH for family planning, how many condoms have been distributed to the community, how many condoms like that. Thank you.
So on the issue of standards and the influx of unbranded condoms.
Standards of what? Come again, please.
The issue of ensuring that condoms, we have a total market approach to condoms in your country.
Okay,
means
yes.
that any businessman can import the condoms. And how do you go about ensuring that the condoms that come into your country are of good quality or with the standards, and ensure that there are no much of a flux of these unbranded condoms that may even end up not serving the purpose of condom?
Okay, thank you. First of all, I would like to inform you that there is a system, proper system in our country where all the procurement, the goods, when they get into our country, they have to be evaluated for their standards. So having the marketing condom, having the social market, the condom, having the free condom, it's not the matter of quality. Sometimes, or even the condom which are being provided for free, it's not that they don't have quality with that of the social market. The issue of standard has been observed all the procurement goods and whatever who are getting within our country. So that one, it is in control. Even for those.
Thank you so much.
Thank you. I can add to that. So TACAIDS, that's the Commission for AIDS in Tanzania, as well as together with the Ministry of Health, they work very close with the Tanzania Medical and Device Agency. Now, this is an organization that upholds standards and quality of goods in Tanzania. Not how they do that. They have agent offices, and they have offices, across all the regions and on the borders, and they actually do routine supervisions at the outlet centers and all at the outlet centers and the pharmacies, to see if the products or commodities that are there are the ones that have been approved by the government. So if I should add more, is that so far they're doing great, but I cannot say that it's 100%, but yes, we have really managed to control the issue of unbranded condoms in the country, based on their practice of regular supervision, and they have agencies, they have offices to the regional level where they audit all the products that are in the outlets centers. So thank you.
Thank you so much. Oh, I don't know if I may still ask if do we have any plans for local production for Tanzania? Do they have plans for local production of condoms?
Oh, well, that has been a long time coming. Yes, we have already started talks on building an industry, condom industry in Tanzania. Of course, that has, as always, all new things actually always take maybe a little bit more time until they come, they come to existence, because it involves talking to policymakers, trying to convince the parliament, the government, on the advantages of having this industry, over the other priorities that are in the country. But yes, that's among the agendas that is in our condom technical committees, on how, first of all, at this point, we're on the level of advocacy. First of all, we want our idea to be agreed or to be understood by decision makers. And then once we are done with that, maybe we'll start thinking of soliciting funds for that. So yes, we already have that in our minds for a longer term, as a long-term plan. And at this point, it's in the very basic, I would say the very basic stage. We're on the advocacy process, or advocacy stage on how or where this industry will be built in the markets. The whole thing about, business, kind of business or any other business. The whole thing about building a new business. So that's what we're doing right now. So we have that at the back of our mind, but then I wouldn't say that it's very soon. It's going to come very soon, but it's one of the things we have in our visions. Thank you. Or if Nigeria, you already have that, a step ahead, would love to learn from you guys. Or any other country.
We are not there yet.
You're not there yet.
Yes, so this is Babatunde, UNFPA. I really appreciate the elaboration on a lot of things. We have a lot of things to learn, I think, from one another. We've gotten some form of traction, and it's just for us to begin to see how we can implement and make our HIV condom programming more robust. So I'm sure we'll get in contact with you through our coordinating agency and see how we could take this discussion beyond this very particular moment. So thank you very much to all the team. Over.
Excellent, excellent. We are more than willing, and you're welcome to have this discussion, more and more discussions like this. Thank you. So I don't see any more questions or new questions, and I don't see any reaction, no hands up. No. So I think that Max, we have a new hand right now. Karibu Ezeni, please, welcome. Oh. Ezeni, please, you can say your question.
Okay, good afternoon, everyone. Mine is not a question, just to say, my name is Ezine Okeuchendo from Nigeria. Mine is not a question, but just to congratulate the Tanzanian team for a job well done. It was nice hearing some of the things that you're already putting in place, that you've already put in place in your condom programming in Nigeria, and especially the ones that were also implementing in Nigeria, including the TMA, the issues around the condom subcommittee, and also that your condom programming is government-led. We've also taken notes on the areas of learning, and we appreciate this opportunity to be part of this.
Ezeni, I think we lost you. Ezeni?
Maybe internet connections, maybe the internet as well.
Sure.
Yeah.
Sure. Thank you. So I think that we do not have further questions, but yes, on behalf of the Tanzanian team, I think I should, yes. There's one more question, I see. No? Oh, yeah, the hand has gone down. Okay, sure. So we, on the behalf of the Tanzanian team, would like to thank you all for a very engaging discussion and all the questions that you asked us. They're really, really helpful. I mean, we really loved and enjoyed sharing with you, and your also the question you asked us, they are really inciting and makes us, I mean, they've made us to think outside the box and even furthermore. So thank you all. Thank you for your questions. Thank you for participation. And I think, as always, there's always room. We can still carry this conversation furthermore beyond maybe this platform. So we can always reach us, and we can always share more in case if you have any clarification or you'd love to learn anything else from, I mean, and something more from us. So thank you a lot. And now I would like to return the mic. Sure. Now I'll return the mic to Lulama or or Maria?
Thanks, Dr. Pendo, and to the Tanzania team. We've just posted a short poll, which should be appearing on your screen right now, just to rate the session and to just give ourselves and the Tanzania team some feedback. And once you've completed that, you're free to drop off the call. Thank you very much, everyone.
Thank you, colleagues. Bye-bye and have a lovely evening, lovely morning to some of you. Bye-bye.
Bye-bye.
Bye, everyone.